In this video, I will cover the basics of using ultrasound imaging of the spine to assist with thoracic epidural insertion. As always, a good understanding of spinal anatomy is essential to using ultrasound imaging. The morphology of the thoracic spine varies by level. The lower thoracic vertebrae are similar to the lumbar vertebrae in shape, whereas the mid and upper thoracic spine, particularly in the T4 to T9 area, have steeply angled spinous processes and laminae that overlap each other. This leads to very small imaging windows in the parasagittal oblique view and no acoustic window into the vertebral canal at all in the transverse view. There are significant differences in the shape of the typical thoracic and lumbar vertebrae. Note how the laminae are flatter in the thoracic vertebra and transition into a prominent transverse process. Unlike the articular processes of the lumbar vertebrae, the articular processes of the thoracic vertebrae do not protrude posteriorly and are not usually visible with ultrasound. These are the structures then that would be seen on the transverse ultrasound view. The spinous process, which marks the neuraxial midline, the lamina, the transverse process, which articulates with the rib, and the pleura. As always, bony surfaces are recognized as bright white echogenic lines with dark acoustic shadowing beneath. The anterior and posterior complexes of the vertebral canal are almost never visible, as there is no interspinous acoustic window in the thoracic spine. What the transverse view is useful for is to map the midline, particularly in patients with scoliosis, or for example the ICU patient with impalpable landmarks due to dependent edema, who is also lying in a soft saggy bed that leads to curvature of the spine. The parasagittal oblique view provides the most useful information. The laminae in the thoracic spine have a flat, plate-like appearance, unlike the sloping sawtooth appearance of lumbar lamina. The gaps between these flat hyperechoic lines is the interlaminar space. Hyperechoic elements within this space are not necessarily the posterior complex. The laminae overlap, so this often represents the cranial edge or lip of the bony lamina and can obstruct needle passage if it is not advanced at an appropriately steep needle angle. Do not always expect to see the anterior and posterior complexes, except perhaps in young patients with flexible spines or in the lower thoracic spine. What information do we gain from these images? Firstly, we know and can mark the transverse plane in which the interlaminar space is located. Secondly, we can measure the depth to the lamina, giving us the minimum needle depth required to reach the epidural space. As we will see later, the actual needle depth will be greater than this. But for now, this represents a safe minimum needle insertion depth. Third, we can mark the position of the midline if this cannot be easily palpated. With these three pieces of information, we should be able to more easily triangulate our needle approach to enter the thoracic epidural space. In general, I recommend a needle insertion point approximately half a centimeter away from the midline to avoid an excessively large lateral-to-medial angle, and 1 to 2 centimeters inferior to the plane of the interlaminar space, which will allow for a cranial angle of 50 to 60 degrees. Imaging is even more helpful if there is a scoliotic deformity, as scanning on both left and right sides of the spine will allow selection of the side where the spaces are more open, or more specifically where the interlaminar gap is more prominent on ultrasound. Note that degenerative disease of the spine with osteophyte formation can result in narrowing of some of the intervertebral spaces or even complete closure. This will not be evident without some sort of imaging, and also speaks to the importance of trying alternative spaces if you're not successful at the first chosen space. This is another example of osteophytes potentially obstructing passage into the epidural space. These recessed osteophytes may, however, not be clearly visible with ultrasound. One of the most important pearls for success is to keep the lateral to medial angle of the needle very small, no more than 5 to 10 degrees. To achieve this, the needle should be inserted just alongside the spinous process, not more than half a centimeter away in a paraspinous approach, which may look very much like a midline approach. Starting more lateral and using a larger lateral to medial angle increases the possibility that the needle may cross the midline and pass through the interspinous ligament into the contralateral vertebral muscle or even into the pleural space, both of which may produce a subjective loss of resistance. Note that this paraspinous approach is also often what happens when a so-called midline approach is used. The needle slips to one side of the supraspinous ligament and advances alongside the spinous process rather than truly in the midline through the interspinous ligament. The reason why it is important to insert the needle inferior to the transverse plane of the interlaminar space is because the overlapping nature of the thoracic laminae results in this bony lip of lamina that lies under the overhanging edge of the lamina above. This will impede a needle that is advanced at a caudal-to-cranial angle that is too large. The angle of 55 degrees that is commonly advocated in regional anesthesia textbooks is the trajectory that is necessary to get past that bony lip into the epidural space. And that in turn is why the needle insertion point needs to be inferior or below the marked level of the interlaminar space. This trajectory also means that the actual needle depth required to reach the space will be greater than that measured depth to the lamina. The vertical depth of the lamina, 3 centimeters in this example, merely indicates the minimum depth that you need to insert the needle before even reaching the lamina. Knowing this safe minimum depth is helpful, particularly in a larger patient, as you then no longer worry that your needle is going in 5 or 6 centimeters or more before you get any tactile sense of where you are. If you start your insertion 2 centimeters inferior to the level of the space and your trajectory is at a 55-degree angle, then now the distance to the lamina is 3.6 centimeters. And thereafter, to pass from the posterior surface of the lamina through the ligamentum flavum and into the space is usually at least another 1 centimeter. So the actual needle distance becomes closer to 5 centimeters than to 3 centimeters. This difference will increase with deeper spaces. In general, expect that the actual needle depth will be greater than the estimated depth by about 1.5 to 2 centimeters. Here is a video illustrating the needle insertion process after scanning and marking. The vertical line on the patient's back is the midline, and the horizontal line is the location of the interlaminar space. The needle, as said before, is inserted 0.5 centimeter lateral to the midline and about 1.5 centimeters inferior to the interlaminar space. The needle is inserted more or less perpendicular to the skin to contact the lamina as a starting point. The needle is then gradually walked cranially up the lamina until it slips off the edge into the interlaminar space. Note as always that the lateral to medial angle is very small and does not change as the needle is walked up cranially in this paraspinous approach. So here the needle is contacting the lamina at the estimated depth of 3 centimeters. At this point, the stylet is removed and the loss of resistance syringe is attached. The needle is then walked gradually off the edge of the lamina into the interlaminar space to engage the ligamentum flavum and to seek the traditional loss of resistance. Note that loss of resistance in this case is obtained about 2.5 centimeters deeper than the initial contact with the lamina. Another thing that ultrasound is useful for is to accurately identify the thoracic intervertebral levels for epidural insertion. There are three ways to do this. First, if you are already familiar with lumbar spine scanning, you can identify the L5-S1 interspace using the parasagittal oblique view and count upwards from there. Second, you can identify the lowermost rib, assume it is the 12th rib, and count upwards from there. Third, and my preferred method for the upper thoracic spine, you can identify the first rib and count downwards from it. To identify the first rib, place the ultrasound probe in the supraclavicular fossa as though doing a supraclavicular brachial plexus block. The first rib is easily identifiable as an elongated hyperechoic structure with a subclavian artery and the brachial plexus lying on it. Slide the probe around the root of the neck and posteriorly staying medial to the scapula. This will bring the posterior part of each subsequent rib into view. The first rounded shadow that appears after the first rib is the second rib. It is not the posterior part of the first rib, as you can appreciate from the graphic. From here on, it is just a question of counting from the second to the third to the fourth to the fifth rib, and so on and so forth. When you have found the rib that corresponds to the interspace that you are interested in targeting, slide the probe medially to visualize the transverse process and then the lamina. It's important to note, however, that because of the cranial angle that the transverse process makes with the lamina that is in line with the rib and tip of the transverse process is actually the upper one, the T4 lamina in this case, and the T5 lamina will be lower or more caudal. So in this case, following the fifth rib will lead you to the T4-T5 space. The T5-T6 space is the next lower one and not necessarily in view on the ultrasound image. This video illustrates this. The first rib is easily recognizable as before, as a long shadow with artery and plexus resting on top. The second rib is the next shadow, and each rib can be counted in turn. Sliding medially from the third rib in this case, we see the T3 transverse process transition to the T2 lamina, and the T2 to T3 interlaminar space is visible. Ultrasound imaging will help you find your way past the bony lamina and into the epidural space. It does not by itself confirm that your needle or catheter will lie within the epidural space, although you can be more confident that any loss of resistance that is obtained is likely to be a true positive loss of resistance. I'm going to spend the last few minutes talking about ways to ensure that the epidural is correctly located once you have found your way into the interlaminar space and that the catheter stays that way. With regard to loss of resistance, saline appears to be the more widely used and taught technique for loss of resistance nowadays, and it does have certain theoretical advantages. It offers a more definitive endpoint than air, and because the injection of saline pushes dura and vessels aside, it may reduce the incidence of dural puncture and intravascular catheter placement. Patchy blocks have also been attributed to air bubbles within the epidural space, and the use of saline may help avoid this. The main argument for using air appears to be avoidance of confusion of cerebrospinal fluid with saline, particularly in combined spinal epidural techniques. This is not relevant in the thoracic spine, clearly. Ultimately, there is no conclusive evidence to support one over the other, and the choice is going to be one of personal preference and experience. The lack of reliability of loss of resistance may be due to anatomical factors such as cysts in the interspinous ligament, or midline gaps in the ligamentum flavum. A false positive loss of resistance may be obtained when the needle passes from the interspinous ligament into the paravertebral muscles or into the thoracic paravertebral space or pleural space, all of which have been described. As I have already discussed, the best way to prevent this is to avoid excessive lateral-to-medial angulation and instead adopt more of a paraspinous approach, keeping the angle to the midline to 5 to 10 degrees. Will a test dose of local anesthetic help confirm correct position of the epidural catheter? The classic teaching is to inject 3 mL of lidocaine or similar with epinephrine, primarily to rule out intrathecal or intravascular placement. An increase in heart rate of 10 beats or more, or an increase in systolic pressure of 15 millimeters of mercury or more, has been shown to have good positive predictive value for intravascular injection in children or in the non-pregnant adult. However, note that if the catheter is truly intrathecal, high spinals have been reported following the test dose, even with lumbar epidural catheters. Will injection of small doses of rapid onset local anesthetic help to confirm correct epidural placement? The answer is yes, but this will take time. Larson and colleagues tested the time efficiency of test dosing, and they injected a total of 8 mL of a mepivacaine mixture over 2 injections spaced 5 minutes apart. Less than 40% of their subjects had detectable loss of cold sensation within 10 minutes of the first injection. A block was only detectable in the majority of patients 15 minutes after the first test dose. And in some patients, it took even longer than that for a block to manifest itself. Epidural stimulation has also been described, particularly for ensuring that the tip is placed at a desired vertebral level. This can be done with either a specially designed epidural kit that allows neurostimulation, or with an adapter that allows connection of a nerve stimulator, or even as some centers are doing by using a peripheral nerve stimulating catheter set. The catheter and epidural space must be primed with saline to allow conduction of current unless there is a conducting stylet located within the catheter. Essentially, a motor response in the truncal muscles is observed at a current threshold of between 1 to 10 milliamps if the tip lies within the epidural space. Anything outside of these limits suggests that the catheter is lying somewhere else. Note that the current threshold will increase after local anesthetic is injected. On the other hand, a motor response at a low threshold below 1 milliamp suggests that the catheter may have exited the space into an intervertebral foramen or may be in an intrathecal or subdural location. Another method that has been described to confirm entry of a catheter into the epidural space is epidural waveform analysis, which only requires a pressure transducer kit and a length of sterile tubing to connect it to the hub of the needle. This makes it accessible to almost everyone. The presence of a pulsatile waveform indicates that the tip lies within the epidural space, and this has a good positive predictive value, although it is still not completely infallible. The sensitivity of the test is increased by injecting more saline, and this should be done if the waveform is absent before declaring misplacement of the needle or catheter. Results from a randomized controlled trial of thoracic epidurals performed by residents showed that the use of epidural waveform analysis significantly reduced primary epidural failure rate, defined as a detectable block within 10 minutes of a test dose. Epidural waveform analysis did prolong block performance time, but it is worth noting that the test prompted reinsertion of the epidural in 40% of the group. While we don't know how many of these were actually warranted, it is likely to have contributed to the overall success in that group. How far should we advance an epidural catheter? If we advance a catheter too far, it can coil, or worse, exit an intervertebral foramen to lie outside the epidural space. If not advanced far enough, it is likely to fall out of the space with postoperative patient movement. Studies in lumbar epidural catheters indicate that inserting it 4 to 5 centimeters into the space is associated with the lowest incidence of failure. There is much less data for thoracic epidurals, but a 2016 randomized controlled trial found that it was important to thread the catheter more than 3 centimeters into the space. There didn't appear to be a significant difference in failure rates between the 5 and 7 centimeter groups, however. So at this time, it would seem prudent to insert at least 5 centimeters of the catheter into the thoracic epidural space. Finally, fixation of the catheter is something for which many options have been described. Suturing requires time and dexterity on the part of the operator and may increase site inflammation. I personally have never used it. Tunneling is an option, but can increase patient discomfort, and there is a risk of encountering difficulty on removal. Studies have not shown it to be superior to fixation devices. Again, I've personally never used it. Various fixation devices are available. Some are more effective than others. However, none of them will completely eliminate the problem of migration, and they will be associated with an increased cost. At the end of the day, what is probably most important is attention to detail and a well-applied dressing to clean, dry skin. Thank you for watching. Check out the other videos in the Neuraxial Blockade playlist for more information, especially on ultrasound imaging of the spine and for lumbar neuraxial techniques.